that 90 to 95% of Alzheimer's disease are sporadic. That is, there is no germline mutation inherited by the person from their parents. But we do have somewhere between 5 and 10 that have specific mutations, and those typically result in the onset of dementia before the age of 50. Now, sticklers might say if it's 53, it's probably still early onset. I would agree with that. So we can either have a mutation in the gene that encodes amyloid precursor protein, that's on chromosome 21. We can have a mutation in presenilin 1 and presenilin 2 that are on different chromosomes, or we can get an extra dose of the gene APP because people with Down syndrome have 3 chromosome 21s. It's a trisomy. So they're getting an extra dose of this gene, even though the gene itself is not mutated. And we do see an increased incidence of dementia in people with Down syndrome early in life. Now, this is something that I want to be pretty clear on. You see a lot in the literature about ApoE and its association with Alzheimer's disease. What I want you to understand is that the presence of the ApoE allele E4, or ApoE, is associated with an increased risk. That doesn't mean that apolipoprotein E is causing the disease. It's just an association, and it's probably due to some genetic mechanism that we don't fully understand. So the more, if you have a double E4, that is, you got an E4 from your mom and an E4 from your dad, that would be the highest risk. One ApoE allele from mom and not from dad, lower risk. So here is a nice summary slide. If you have a triple dose of amyloid precursor protein, you have 3 genes. The onset of dementia will be in the 20s to 30 age range. These are people in Down syndrome. Then you have sort of the early 40s, the 2 presenilin 1 and 2, inherited again. And then if you get a mutation in the gene encoding amyloid precursor protein, that should be also before 50. Now here's the thing about ApoE. It affects the stability of the beta amyloid deposits. So the more, if you have 2 alleles of E4, that's the worst. That is, that may, here's the thing, the population stats show that people who have an onset of dementia in their 60s and 70s are more likely to have an E4 allele, and the ones that get onset over 80 are less likely to have an E4. So that's the meaning of apolipoprotein E. And here's a karyotype with Down syndrome. So some of these mutations are encoding proteins near the beta and gamma secretase cleavage site. So that's why they affect the likelihood of developing this abnormal amyloid beta. And the 2 loci that cause most of the early onset familial Alzheimer's disease are these 2. So mutations in presenilin 1 and 2. And both of these lesions lead to a gain in gamma secretase function. So you're saying, what does that have to do with anything? So if you have a gain in gamma secretase function, you're going down this pathway more often, that won't hurt you. But if you have some beta secretase cleavage and you have more gamma secretase activity than normal, then you will be processing this abnormal protein more often. You'll get more of it accumulated. And that especially, these 2 mutations are especially associated with too much of the toxic amyloid beta 42. I was talking with Dr. Krispolsky at the break. Amyloid beta 40 and amyloid beta 42 are bad brothers. They're both abnormal proteins. When we say that there is normal amyloid precursor protein and bad, both 40 and 42 are pathologic. Okay, and I think I've already talked about apolipoprotein. The dosage increases the risk, but it doesn't, we don't know that it causes the disease. So here's our summary. If you have either a mutation in APP or a trisomy, then you're going to get early onset familial Alzheimer's disease because of that, increased amyloid beta. Presenilin 1 and 2, these are the kind of mutations, increase amyloid beta. And if you have, these are not abnormal apolipoprotein E's, they're just normal alleles. E2, E3, E4 exist in our population. The more you have of that, the more the increased risk of younger onset. So I'm going to switch gears here now. And part of the confusion about what it means to say Alzheimer's disease is because clinicians and pathologists have different criteria. As I mentioned before, if a clinician sees a 75-year-old man who no longer knows how to dress himself or get to work and has bad memory, and he has an MR scan that shows atrophy of the temporal and frontal lobes, he's going to say, that's Alzheimer's disease. And he's right most of the time. The neuropathologists, on the other hand, have tissue findings that enable us to say, we think this is the kind of pathology that occurs in people who have dementia. So what we've done, and this is, the neuropathologists are kind of sticklers for detail, they will now use, and I use this on my path reports, I don't say Alzheimer's disease on my final pathology report, because that's kind of a clinical interpretation. I say there's Alzheimer's disease type neuropathologic changes. This term refers to clinical signs and symptoms of cognitive dysfunction that are typical for those who have the underlying neuropathology. But my job is to identify the amount and the distribution of the neuropathology, and the clinician then is deciding whether that neuropathologic change is enough to explain the patient's dementia. Let me tell you why this is important. Let's say that at autopsy, I find a modest amount of Alzheimer's disease neuropathologic change, but I also identify arteriolosclerosis in the small arterioles of the brain. Two diseases are present in the brain. One patient has dementia. So the clinician could say, when they're talking to the family, this, your loved one had a couple of things going on that contributed to their dementia, and one of them is simply a vascular disease that is very common in the population and has no increased risk for your loved one's offspring. Arteriolosclerosis, very common, it's associated with high blood pressure. So that would be some useful advice for the sons and daughters of the loved one who had all. On the other hand, when we say you had Alzheimer's disease neuropathologic change, even though it's not inherited, that imparts somewhere between a 1.5 to 2 times increased risk for the children of the man or woman who had AD to develop AD. So there's different genetic counseling implications, and that's why we separate these things out. So here's how we do it, not to be memorized. I just want to acquaint you with the sort of the arithmetic and how we do it. So the first thing we do is we look at 3 different things. We look at the amyloid beta plaque score. Okay, now what is this? It's not the number of plaques. It's where they exist. And there are seminal work by a neuropathologist by the name of Thal said that in this early stage, we don't have any. In stage A1, we find the plaques only in a couple of places, predominantly the temporal lobe, and they're not going to be in the parietal lobe or elsewhere. Then they start to be found in other places in phase 2, in phase 3, and in phase 4 or 5. They're in the midbrain, they're in the brainstem, they're extensively in the cortex, cerebellum. So this is the extent, geographic extent of where we find the plaques. Then we actually count them. And this is the arithmetic, none, sparse, like we're looking at a microscopic field with our amyloid beta immunostain, and we're just seeing 3 or 4 plaques, neuritic plaques. That would be sparse. Same size field, we usually count at 100x. If I see 8 or 10 in that one field, now I'm up to CIRAD score 2. And if I see 40 in one 100x field, now we're high. And then the last stage has to do with counting neurofibrillary tangles, and they have to do again with distribution, not the number, but where are they located. And then, since we know that all 3 of these can contribute to the development of dementia, we basically combine them. And this whole scoring system was developed about 8 years ago, and it took them a long time to agree on what should be the way we do it. So here's how we count the plaques. So in this particular field, there's 5, 10, about 20 plaques that I would count. And here's how we do it. Now, this is really interesting. This is, you get a feel for what sticklers the neuropathologists are. So here's my Thal score based on how the plaques are distributed. Here's my number score, and here's our Barak stage for neurofibrillary tangles. B1, 0 stage, B2, B3. So they're using 3 variables. And this statement over here is how likely is the neuropathology to explain the presence of dementia. And it shows you how modest the neuropathologists are. They only say there's a high likelihood if you have the highest Barak stage, the highest number of tangles, and the widest distribution, not tangles, plaques, and the widest distribution of plaques. Everything else is intermediate, and then these are low. So basically, the neuropathologists say, we're not gonna say this is the cause of your dementia unless it's like rampant disease. Very modest approach to things. So here's one way I would put this on a report. My examination of the brain, I have neuropathologic changes. I don't have Alzheimer's disease. I have the changes that have been associated. Intermediate level, my plaque score, my tangle score. Here's the plaque score, the distribution of the plaques. And then I say, see discussion. And the discussion goes into this kind of talk, and the other part of the discussion goes into what's the risk for the offspring of developing Alzheimer's disease. Here's some other things that cause dementia. So now I'm switching gears. I'm leaving Alzheimer's disease. Vascular disease, disease of the blood vessels. So here's disease of the big blood vessels, atherosclerosis, which is the same disease that hits the coronary arteries and causes heart attacks. Here we have atherosclerosis that's not occlusive. It doesn't close off the artery, and it's affecting here. Here's the disease that is probably the second most common cause of dementia, is arteriolosclerosis, especially when it's severe. And then, sometimes we may actually see an infarction, which is an area of tissue that has died due to lack of blood supply. That's the definition of an infarction. So we may see an infarct in the brain. This I diagnosed grossly with my naked eyes. 3 centimeters in diameter, here's a smaller one. So we always report the vascular disease. Here's what I mean by arteriolosclerosis. This is a picture from one of my autopsies showing that these arterioles have very thin muscular walls, usually 1 or 2 cell layers thick, maybe 3, and the lumen, all this red, is red blood cells. Here's an arteriosclerotic vessel. All this thickening is a combination of thickening of the middle muscle layer and the intimal layer with collagen or scarring, resulting in a lumen that is probably 1/2 to 1/3 the original diameter of that arteriole. So this will cause chronic deprivation of oxygen and glucose and other nutrients to neurons and will promote neuronal cell death. Here's a little tiny lacunar infarct that is identified on an MR scan. That's pretty tiny, but MRs are pretty good these days. Now here's another disease that I've only diagnosed twice in my life. First time, I didn't know what I was looking at, so I sent it to the University of Chicago, and a really good neuropathologist there said, "I'm so glad you sent this to us," and she generated a report about a month and a half later, so she had shown it to all her fellows and residents, and that's when I learned about how to make this diagnosis. So, in people under 65, which not many people under 65 have dementia unless they have that familial disease, this is a common diagnosis. The pathologic changes are prominent in the same places as Alzheimer's disease, frontal and temporal, but the clinical findings are typically a little different. In these people, they have abnormal personality behavior before they get memory loss, such as they start blowing up at people, getting angry or aggressive for no particular cause. Or they start doing things that are considered by their loved ones, things they've never done before. So kind of personality behavior preceding, that's a soft criteria. But look at the pathology here. The abnormal protein in neurons is the tau in most cases. It's not amyloid beta peptide. Now remember I said tau was in the neurofibrillary tangles in Alzheimer's disease, but in this one, it's the main thing that's going on. And then sometimes it's an accumulation of this RNA binding protein, so there's 2 subcategories of FTLD, which I was taught by this neuropathologist at University of Chicago. And so now the current classification is this type of frontotemporal lobar degeneration or this type, and that's determined by immunohistochemical stains looking for that particular protein in neurons. So here's a patient with frontotemporal lobar degeneration. Here's an antibody against the tau, and you can see how much tau has accumulated here. Here's tau within a neuron that hasn't died yet. So these 3 neurons all have excess tau, and these are sort of the graveyards of dead neurons. And here's one against FDLD TDP. Looks very similar. The only way you're going to make this distinction is to have the right antibody to detect the protein, and they both present similar clinically. All right, moving on to some degenerative diseases that are not primarily in the cortex, but they're in the basal ganglion brainstem. 2 most important ones are Parkinsonism and Huntington's disease. And unlike cognitive difficulties, these diseases present with abnormal movements. Rigidity, abnormal posturing, fixed posturing, stiffness, and chorea is like the waving motions of the extremities or the head with involuntarily. And the basal ganglia all play an important role in positive and negative feedback from the brain going to the cerebellum and the motor cortex. And when those signals get mixed up in the basal ganglia or the brainstem, our movement is affected. Now that's a very simple explanation. It's far more complicated than that. But I do know how this disease is diagnosed. So Parkinson's disease is when we see, classically, the death of the pigmented neurons right here in the substantia nigra of the midbrain, and those neurons secrete catecholamines. And so as those neurons die, they accumulate, guess what? What do you think they're accumulating? Abnormal proteins. Every one of these diseases is an abnormal protein. In this case, it's alpha-synuclein that's accumulating in these neurons, and we call those Lewy bodies. Here's a cartoon of them. Here's the neuron nucleus, here's the cytoplasm, and here are these red Lewy bodies. I'll show you a picture of them, yeah, in a minute. So anyway, that's the morphology. Here's where we find them in this very specialized location. It's called nigra because when you cut the brain, the tissue is black. It's the accumulation of this catecholaminergic biochemical, dopa, or dopamine. So 15% of individuals who have the Parkinson's disease, that's the movement disorder, eventually get dementia. And that's because the same process of accumulation of misfolded alpha-synuclein starts to deposit in the cortical neurons, and then they develop dementia. Very odd, sort of unpredictable clinical behavior. It sort of worsens and gets better. They can have visual hallucinations. They can have problems with judgment and decision-making, frontal lobe signs, but it's these presence of the Lewy bodies in a wide range of cortical location that gives us dementia with Lewy bodies. So we call that Lewy body dementia. Fourth most common cause of dementia in the US after Alzheimer's disease, neuropathology, arteriosclerotic disease, and frontotemporal lobar. Now, in this case, when you have them up in the cortex, in the frontal lobe, they're much more difficult to detect without a special stain. So that's why if we have a history of somebody who had a movement disorder or odd changes other than just memory and executive function, we do these stains and we look for the accumulated alpha-synuclein. So here's the H&E, a little bit subtle, but this particular neuron has a red core of abnormal protein in it. And if we do the stain, we do an antibody against that abnormal alpha-synuclein, it lights up brown. And here are this is a dopaminergic neuron or a normally brown pigmented neuron, because it's dopamine in there. And these little red halo, well, they're a red dot with a halo around it. Those are the deposits of alpha-synuclein. We did the immunohistochemistry and we actually see there's more than we thought. Next one is Huntington disease, and just to review, Alzheimer's disease is frontal and hippocampal. Parkinson's disease is substantia nigra and can be in the frontal cortex. Frontotemporal lobar degeneration, which is not on this thing, is the same locations as Alzheimer's disease. And now Huntington disease is this caudate nucleus and maybe portions of the cerebral cortex, the frontal lobe, that is. So here we go, autosomal dominant, gotta have genetic counseling for the offspring of people who develop Huntington disease. Progressive movement disorder, and this is degeneration of particular types of neurons, the striatal neurons in the caudate nucleus. Hyperkinetic, jerky motions involving all parts of the body. I don't know how to describe this except that it's very disconcerting to the people around those who have these choreiform movements. And you feel sorry for the person, you just wish there was some way you could help them, but you can't. These are involuntary movements. They may later develop Parkinson-like symptoms, but early on they have this characteristic chorea. This is a death sentence. Once you start to develop this disorder, you're going to die. The average course is about 15 years. which is not merciful because that means you've got to put up with this for 15 years knowing you're going to die. Molecular genetics. So here's the Huntington disease that encodes a Huntington protein, and that's the normal. We all make Huntington protein. In the first exon of the gene, there's a stretch of 3 nucleotides, trinucleotide, they're CAG, and they encode a region at the N-terminus of the protein. So here's our whole chromosome. This is the gene we're talking about. And what happens, and I think this is a nice visual of what we mean by trinucleotide repeats. So here's this gene encoding, here's the genetic material, so we're interrogating the nucleotides in the gene, and if we see less than 35, each one of these little boxes is a CAG, so it's going CAG, 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 one right after the other. Less than 35, you're not at risk for Huntington. Maybe if you've got 36 to 39, and if you have more than 40 of these in your gene, you're probably going to get Huntington. Now, if you were 12 years old, would you want to know that? It's a tough call, right? Like, I did an autopsy on a man who had known Huntington disease, fully diagnosed by the neurologist. They wanted me to do the autopsy, and they said, look, if this will help some of your medical students understand this, it's not a question of what's wrong with him. So I did the autopsy, and then in my report, I raised the question. He had 3 children, and I said, you know, they can be tested genetically to find out if they're at risk. But remember, it's autosomal dominant, right? Guess what? All 3 of those children said no. I do not want to know, because I saw what happened to my dad, and if that's going to happen to me, so be it. But don't put this cloud over my life now. Very, very sensitive sort of genetic counseling. And what happens, here's the interesting, why we call it expansion, in each generation of people who have this trinucleotide repeat, the number of repeats gets larger in the gametes, in the sperm or the ova. So the next generation will get the disease earlier, and so on and so forth. These are just the range of clinical features. Most common, the onset is in the 20s or 30s, and the more CAG repeats you have, the earlier the onset. And the movement disorders precede the cognitive impairment. First symptom, involuntary movements of a choreiform type. There's the disease, it's in the caudate nuclei, that's where it starts. Can involve the putamen also earlier, and the globus pallidus. The atrophy of the caudate and globus pallidus and putamen results in a increase in the size of the ventricles, just like Alzheimer's disease. If you lose volume in your caudate nucleus, the ventricles are right next to the caudate, so they're going to expand. Here's a normal brain. Notice the shape of the ventricles, because the caudate nucleus sits right here on the lateral walls of the lateral ventricles. And when that caudate undergoes atrophy, the ventricles expand. Now, this is a funny picture. It's not, they shouldn't be asymmetric like that. Usually it affects both sides equally. This is just an odd picture. So here's the shrunken nucleus under the microscope. This is a simple H&E stain. Normal caudate nucleus, all these neurons are present. In Huntington's disease, all the neurons are gone, and the extra nuclei you see in there are astrocytes. Astrocytes respond to death of neurons by undergoing proliferation or increased number of cells. Okay, so the pathogenesis, if you lose these neurons, it dysregulates the circuitry that modulates your motor output from the motor strip down through the basal ganglia. So normally these neurons dampen those motor neuronal messages. When you lose that dampening, you get a dysregulated output that basically tells your body to move when it shouldn't move. That's overly simplified. And we may, cognitive changes may be related to the same problem in the cortical neurons. And this is what's weird. As of the making of this slide, which was 4 or 5 years ago, we don't even know what the function of Huntington protein is. We know what happens when there's too much of it, but we don't really know what it does. So somebody can find that, send me an email. That'll be your homework. Yes. I don't have time to look. I'm just kidding. If anybody in this class can find out what Huntington protein does normally, send it to everybody else in the class, because I'd really like to know. Let's see. Oh, this is just showing the criteria for Alzheimer's disease and their association with age. I think we'll let that go. Now, different topic. Neurodegenerative disease among soccer players. November 2019, my favorite medical journal, the New England Journal of Medicine. What's the primary cause of death among soccer players compared to controls? Here we had 23,000 controls. This was a big population study, and 7,600 former soccer players. Any cause of death? Okay, they have less of a cause of death to their age-matched controls. So, if you will, they're healthier somewhat. They're athletes, right? Heart disease, less heart disease. The ratio is below 1. Lung cancer, less lung cancer. Neurodegenerative disease, whoops, 4 times higher incidence of neurodegenerative disease compared to their age-matched controls in this study. All right, what are we going to do about this horrible disease? So here are a summary, Journal of Internal Medicine, all the drug development for Alzheimer's disease from 1984 to 2014. 30 years of research trying to develop a drug that will help with Alzheimer's disease. Drug development in this area is a major political, academic, industrial effort. Billions of dollars are being spent on this because Alzheimer's disease is now the number 5 most common cause of death in the United States. It's a massive public health issue. Despite considerable advances in knowledge about the pathogenesis, I showed you all that fine detail of what's going on biochemically and molecular. And in chemistry, no practical treatments have been introduced over 25 years. And I just spoke with my geriatrician colleagues. We're going to do a session for the med students in January about Alzheimer's disease, and they still have no FDA-approved drug that is shown to alter the downhill progressive course of this disease. So, here's a question for you. Here's our model of the pathogenesis of Alzheimer's disease. Repeat, alpha followed by gamma, always good, normal, soluble product. Beta followed by gamma, bad guy, makes the protein. So if that's true, which targeted therapy would have the highest benefit for patients who have early onset Alzheimer's disease? What would you want to do? So we presented this question to a bunch of medical students, and guess what? They didn't agree on the answer. And that's because none of these have been found to actually work, so you can argue about it. You can say, well, wait a minute, if one of those inherited genes, the presenilin gene, upregulates the activity of gamma secretase, why don't we inhibit it? That makes sense, it's logical. So that's a good answer. Here we go. What if we upregulate alpha, which is the one that cleaves it at the right place to keep us making the bad guy? Well, let's do that. Let's upregulate alpha. Why don't we inhibit beta so that this bad cleavage doesn't occur? I mean, all of these are very reasonable hypotheses, right, based on this model. So here's the bad news. New England Journal of Medicine, 13, 14, 14, 18. We made this drug that inhibited beta secretase, no benefit for cognitive improvement. Then we made a gamma secretase inhibitor, no benefit. A thing that bound up amyloid to prevent it from aggregating, no benefit. And an anti-amyloid beta monoclonal that glommed on to amyloid beta and tried to prevent it from accumulating, no benefit. And here are the trials. All of these developed with great hope, and all of them showed no benefit. So here's, before this morning, I was looking for some place that would summarize any new developments that had occurred, because honestly, I hadn't looked at this in over a year. Are there any new drugs? So I found this one, and you'll get a copy of this. This is published about a year ago, Nature Reviews of Neuroscience, a respectable journal. And they said, we're looking, in this review, it's a lot about metabolic and biochemical pathways. This is talking about novel insights about apolipoprotein E, endocytic system. Endocytosis is how a cell takes in something from its environment. Metabolism of cholesterol, what activates those glial cells, the macrophages of the brain that are part of surrounding the neuritic plaques, and the amyloid beta independent regulators of tau. Maybe we can work on tau for a while. Let's leave amyloid beta alone. So they discuss all these things, and then their conclusion is, what are the implications for current treatment strategies? We've already shown that if we focus on amyloid beta, nothing works. So they're saying, well, let's focus on something else. Let's talk about the amyloid beta independent regulators of tau and see if that works. So they're suggesting that maybe the next wave of pharmaceutical research that will target processes that are upstream of the formation of amyloid beta. And, you know, not a bad idea in my estimation, but I honestly don't know where we should target. I was very hopeful that one of these agents would help, but it just hasn't. So my guess is if somebody figures this out, they're up for a Nobel Prize, in my estimation, or some big medal, because this would help literally millions and millions of people. So with regard to prevention or treatment of the symptom progression, there is no level 1 evidence for a neuroprotective effect for anything, despite television ads claiming such things. And this is from Caselli et al., Mayo Clinic Proceedings, 2017. So you hear, in fact, level 1 evidence, okay? So non-steroidal drugs, estrogen replacement, vitamin E, vitamin B. I'm not saying that these studies are unscientific. Many of them were done very well. I'm just saying there's no hard evidence that doing any of these things is going to prevent the development of this disease. All right, challenges ahead, Nature Review Neurology. Now, here we're getting into, we're almost done here, the paper that Dr. Krespolska shared with me of a blood test becoming available and rolling out for clinical use. I don't know the research that's gone in behind this blood test, but here are the things that we know we can measure. We can do cerebrospinal fluid and quantitate the amount of amyloid beta 42 in the fluid, and that may give us a prediction about the likelihood of Alzheimer's disease developing. This is preclinical. This means before dementia happens. We can do a PET scan in which the tracer binds amyloid, and the amount of binding might be proportional to the likelihood of Alzheimer's disease. Or we can look at tau in cerebrospinal fluid. We can look at a plain old glucose uptake PET scan. We can look at measures of atrophy and say, okay, this much atrophy, this much likelihood, et cetera. All of these are not unreasonable ideas, but if you have no treatment, kind of an academic exercise. So here's the staging, and this is done with the NIH. This is basically a combined pathologic and clinical staging. Asymptomatic, but amyloidosis is present. Amyloidosis by whatever mechanism, CSF, functional imaging, and evidence of degeneration, and then here come the cognitive changes. So there's a lot of clinical and pathologic work going on to try to identify these preclinical stages. And then some stage 0 has been proposed, older individuals with no evidence of anything bad. This would be my great uncle who lived to 106 and, you know, could do crossword puzzles at 106. Yes, sir. Yes, so his question was, for those of you listening online, those studies where I showed no benefit, were those people who had cognitive impairment, or were they in the preclinical stage? These are people who had some degree of cognitive impairment. And the problem with doing it on the preclinical is we would have to agree what is our study population. So the closer we get to stage 1, the more difficult it is to separate normal and abnormal people. But maybe these studies in the preclinical phase are being done, but I guess the political pressure was on what do we do for people who already have the disease, in which the cat may be out of the bag then, right? You can't affect it once it's gotten to that place. You're good? Right. Maybe if we looked at people with stage 1 preclinical, just a little bit of cerebral amyloid deposit by whatever, and tried the drugs in them, maybe. Yeah. Yes. His suggestion was maybe we could do some of these studies on preclinical by doing it on families who have early onset inherited basis for Alzheimer's disease, because those people are looking at a bad outcome, so maybe they would be willing. And it's an excellent idea. And there may be studies already happening on these groups. I just haven't reviewed all the literature. Yes, ma'am. Okay, so if they have early onset Alzheimer's disease and you know which gene is mutated, which is easy to find out, then you just test for that mutation in the offspring. Okay, so that's pretty straightforward if you want to know. Okay, now what I said was in these people with sporadic Alzheimer's disease who do not have a germline mutation in anything, if my father had developed Alzheimer's disease in his 70s, my risk of developing Alzheimer's disease is only about 1.5 to 2 times higher than every human being in the United States. That's not a very big risk. And I would say, well, you know, so that doesn't mean too much to me. My biggest risk is getting older. That's more important than my father had Alzheimer's disease, because it goes 1% under age 65, 5% in the late 60s, 10%, and over your high 80s and 90s, 40% of people have. So age is the biggest risk factor, except if you have the inherited familial. time. Okay. Yes.
So what would the clinical significance be of a treatment that you're going to be using before there's actual clinically diagnosed Alzheimer's disease? How many patients do you think would actually be coming in before they're diagnosed with Alzheimer's disease who would be able to even receive this treatment?
So let me see if I understood your question. The acoustics were not so good. Are you saying what would be the clinical significance of doing genetic studies on preclinical phase, or what were you asking?
I mean, from looking for a treatment perspective. So if you're looking for a treatment and you're looking for that treatment in a preclinical group, is that going to be translatable to like clinical practice?
So you're saying if we do studies looking at the effects of treatment on people in preclinical dementia, would that be transferable to those who have dementia? Is that what you're saying?
Correct. Or like how many people would be in a preclinical stages who would come in to even be candidates for this treatment if the trials were to work?
Okay, so I'm not sure if I understand everything about your question, but I'll just respond to what I think I understand. And I would say that the number of people in the United States who have some objective evidence of amyloid deposit in their brain, but they're not clinically demented, that would be a lot of people. So if you were to do a therapeutic trial in that group, and you would have to have a bunch of people who were not treated, so you'd have to have the control group, no treatment, and the experimental group treated, and looked at the incidence of clinical dementia developing in those two groups of people. I think that would be a valuable study. It may be going on right now, for all I know. Is that what you were asking?
Not exactly. I'll shoot you an email.
Can any of you understood what she said? They're all shaking their head. So, you know what? If you could email me the question, if I didn't really answer your question because the sound is a little funny, I can put a response and send it to Dr. Krispolska and we can disseminate it that way. Okay. Okay, so this is my last slide, and what time is it? So we're just about done. I do want to take cases. So this first description of early onset Alzheimer's disease was first the idea was over 100 years ago that these people with plaques and tangles, that we associated that with dementia. This is a neuropathology journal, so they're basically going through the history of how we came to the conclusions. And then the next question was, can we find pathologies that correlate with people with dementia? And that happened in the 60s and 70s, and it was shown that the presence of plaques and neurofibrillary tangles does correlate with people who develop dementia. Then we did the early onset group, and do they have the same disease? And that assumption was made by Katzen, and now it is widely accepted. Now, could amyloid plaques be a marker of Alzheimer's disease? And yes, they are. And then they could provide clues to causality. That's what we believe, because now we know the genesis of the neuritic plaques has to do with the processing of amyloid precursor protein. So that was the amyloid hypothesis, and that began to be developed in the 80s, as well as the hyperphosphorylated tau hypothesis, both proven by pathologic exam. And then could these be a marker irrespective of age or phenotype? And that is what we're saying now. We're kind of in the age now where we can identify tau and amyloid before autopsy. We can look at blood, cerebrospinal fluid imaging, so we can kind of identify the pathologic correlates in the living. And that may signal sort of a transition in research toward doing our studies on living people who have evidence of these pathologic processes, and including those who are in the pre-dementia stage that have evidence of the pathology. So I am grateful to Dr. Krespolska for allowing me to spend some time with you, and it would be fun if you could ask any question that may be on your mind, and I'll repeat the question for the audience online. Yes, ma'am.
Have there been any studies that have shown success in heat shock proteins?
In which proteins? Heat shock proteins. So the question was, have there been any studies looking at, is this would be the treatment or just identifying them in the pathogenesis? Yes. So I am not aware of any literature about correlation of heat shock proteins and neurodegenerative diseases. I'm not saying it hasn't been done, I'm just not aware of it. Yes, ma'am. So are you saying, is there a gender difference in how this happens genetically? I'm not aware of that being shown. It's an indiscriminate disease. If you look at the incidence of the development of AD in the population, men and women don't show any significant difference. It's age. Other questions? Yes, Dr. Krespolska.
First of all, when you are showing the data that soccer players are developing much more frequently neurodegenerative diseases, I'm not sure how many Americans can correlate kicking the ball with neurodegenerative disease. Yeah, so you have to understand that soccer players are hitting the ball with their head very often, and then hitting the ball with the head is like getting hit by Muhammad Ali in the court, and then you're done with play. You're not resting 10 seconds.
Yes. So Dr. Krespolska was commenting on that increased neurodegenerative disease in the soccer players, and he said, we want you all to understand that these soccer players, the professionals, are using their head to hit the ball frequently, as opposed to us amateurs are not good enough to know how to do that. So, but so I don't want to go sidetracked, but chronic traumatic encephalopathy, football players, boxers, soccer players who hit their head many, many times, does have some overlap in the pathology of Alzheimer's disease pathology. It's not exactly the same, but there's overlap. Yes, yeah. And there's a movie on that if you enjoy those kind of things. Yes, he's mentioning the prion diseases and how fascinating those are. That's a world of its own. How can a normal protein change to cause a disease? Yeah. So his question is, diseases like chronic traumatic encephalopathy, are they seeing the same accumulation of proteins? Not necessarily in the same distribution, but the abnormalities of tau and or amyloid protein, yes. Now, remember the amyloid beta peptide pathway of making abnormal amyloid beta 40 and 42, that's kind of a specific process for Alzheimer's disease neuropathology. I'm not as sure about that, but definitely the tau abnormalities are seen in traumatic disease. Yes, ma'am. So she's saying multiple concussions early in life, increased chance of neurodegenerative disease? Absolutely. So it would correlate with the severity of the concussions and the number of the concussions, which is why when a football player is knocked semi-conscious, they don't send him back in to win the game. Right? That's what used to happen with athletes. Can you walk? Can you talk? Get back in there. No, that's not right. We shouldn't be doing that. You can argue whether we should be even playing football, but that's another story. Any other questions? Dr. Kospolska?
So you are saying that we still don't know what is the actual function of Huntington protein, but we also have no idea what is the actual function of beta amyloid. We actually have the beta secretase, special enzyme producing beta amyloid. We evolved for millions of years producing this enzyme. So we need beta amyloid for something. We don't have any protein, at least as far as we know, which is not needed. If we don't need something, we stop producing it. And we are still producing beta amyloid. It's not pathology, they are producing beta amyloid.
Yeah.
Pathology is producing too much of it. So it's probably very important to treatment of Alzheimer's to actually knew what beta amyloid is doing.
So Dr. Kospolska, for those of you who are online, made a very important point. And he says, not only do we not know what Huntington protein does, we don't know what the normal function of amyloid beta protein is, because we do have a beta secretase, it's normally there, so we are making some of this. But why are we doing that? What's the purpose? What's the function? So let's enlarge the homework assignment. If you can explain the function of Huntington normally, or if you can explain the function of amyloid beta, normal amyloid beta, not ones that have accumulated, what do they get a prize?
I think,
No.
I think they can get egg.
Yeah, we'll just say that it will be something that will warm your own heart intellectually if you can find that, okay? And that's enough, right? Learning should be self-fulfilling. Anything else? All right, well, thank you very much. It's been a privilege for me.
All right, thank you.
All right.
There's a question.
All right.